Illinois. So just to remind everyone about roll call, please remember to type your name and organization into the chat box so we can keep track of attendance. And if multiple people are with you from your organization, please include everyone's name. So just a reminder about CEs. You must complete the evaluation in order to receive CEs from APHA, and the email evaluation link will come from the email address that's listed on the slide. The slides and the recording from today will be posted to Moodle by tomorrow. And if you are watching this session as a recording and you were not here during the live session, you have until next Tuesday, August 13th, to post a reflection on the reflection forum in Moodle. And we heard from a few folks last month that you had some difficulty locating where the forum is on Moodle. So we're actually going to pull it up right now. Ufoma is going to pull it up for everyone just to show you where on Moodle you can find the reflection and how to post one.
And share it.
Just give us 1 second.
Anyone admit that person. Jen.
All right, hi everyone. You can locate the forum by logging on to Moodle and going to the welcome page, and on the left-hand side of the screen, you're just going to click on the session title and scroll down, and underneath you will see the forum located, and you're just going to click on the forum and we're going to add a new discussion topic, and then here is where you can input your review of the session. Also, early next week, a midpoint review or midpoint test will be posted, and you can locate that by going again to the left-hand side of the screen, clicking on the welcome page, and the midpoint test will be located underneath the pretest.
Okay, thanks, Ufoma. So as Ufoma just mentioned, we will be posting a midpoint evaluation by next week, hopefully by Monday or Tuesday. It will be posted to where she just showed you on Moodle, just below the pre-test that you took at the beginning of the ECHO. And this is really just an assessment for our purposes, just to see how you think things are going so far, how you're benefiting from this project, what kind of improvements can we make, is there content that you want more of? Since we are at the halfway point, this is a good opportunity to kind of take a pulse check on how things are going. So your feedback is really critical to making this a success. So look for that early next week. I will send out an announcement when that has been posted, and it will be very brief, just a few questions. So if you could please complete that within probably a week is what we'll give folks. And then another thing, case presentation sign up. So if you have yet to present a case or sign up for a date, I sent around an email last week asking folks to sign up. I only heard back from a handful of folks. So if you have not yet signed up for a date, please contact me. We still need at least one more volunteer for next month. And then I don't think we have anyone signed up in October. So we still have a few more slots. And we have a few few more participants than we do have slots for 2 cases per the remaining sessions. So what we're hoping is that we will be able to squeeze in maybe 3 cases on a few of the remaining sessions, but we really want to make sure that we get to everyone. So please let me know if you have not yet signed up for a case, and I will circulate the current sign-up schedule this week. So hopefully we can finalize that. Okay, so I am going to pass it off to our guest presenter, Dr. Kiroglian. So he's going to be speaking about behavioral health and substance use for LGBT folks, especially adolescents. So I'm going to pass it off to Alex. I'm going to stop sharing. Alex, you can take over.
Great, will do. Can you all see my slides?
No.
Not yet? Okay.
So Alex, if you go to the toolbar, okay, yes, you've started,
Yeah.
got it,
Okay,
thanks.
there we go. Hi, everybody. Great to be here with you. Looking forward to the next hour. Hopefully this will be more of a dialogue, particularly at the end. We'll try to leave some time for discussion. And it's a pleasure always to work with the School-Based Health Alliance. I'm on faculty for the Adolescent ECHO. They've run the last couple of years in the winter, so thrilled to be participating in the Adolescent HIV Prevention ECHO as well. I'm going to be speaking about LGBTQ mental health and substance use disorders, how to screen for these, how to address them, broadly speaking, and the relationship these have to HIV risk. So per the request from SBHA, we're going to focus on recognizing unique mental health and substance use disorder concerns for LGBTQ adolescents, the impact these have on HIV risk, how to increase your own capacity to screen for mental health and addictions, mental problems and addictions in high-risk adolescents, and make linkages to treatment, as well as some systems-level interventions to facilitate that. Broadly, too, and I see my former friendly colleague, Molly McHenry here on the ECHO, so she's probably heard this a thousand times, but it's helpful to understand the mental health and addictions-related disparities, in fact, all health disparities among LGBTQ youth through a minority stress framework. This is something we increasingly use in clinical care, in research, and in policy. The idea here is that LGBTQ youth grow up with everyday discrimination, victimization, microaggressions, frank violence, unfortunately at a much higher prevalence than the general population. All of this we think of as external stigma-related stress. These external stigma-related stressors can take their toll over time, and for many youth lead to disruptions in general psychological processes like coping mechanisms, emotional regulation, interpersonal functioning, cognitive structures that aren't adaptive, like believing it's never going to get better, nobody can be trusted, no one will ever love them. And all the external stigma-related stress over time can lead to internal stigma-related stress, internalized homophobia, internalized transphobia, believing all the negative things society has to say about your sexual orientation or your gender identity, expecting rejection because you're so accustomed to it, and identity concealment, including in the context of healthcare, which is why collecting data on sexual orientation and gender identity for all our patients is so important and now required in the UDS by the Bureau of Primary Healthcare. All this stress can take a toll, and as you can imagine, for many youth leads to what we observe in the research, which is a much higher prevalence of behavioral health problems among LGBTQ youth, including depressive disorders, anxiety disorders, post-traumatic stress disorder, and substance use disorders as a way to cope with all that stress, as we'll discuss more in a little bit. This is associated with decreased self-care among these youth, decreased engagement in primary health care, and down the road, a much higher prevalence of various physical health problems. than what we observe in the general population, including much higher prevalence of HIV infection among sexual and gender minority people, with men who have sex with men and transgender women, both being the populations with the highest incidence and prevalence of HIV in the US, particularly among Black and Latinx populations. We think of stigma in three categories. The first is interpersonal stigma. This is perpetrated between individuals. It can be between a member of a care team and a patient, for example. It starts young on the playground, for example, and continues into older adulthood. It can be perpetrated between a member of a care team and a patient. Structural stigma refers to institutional or governmental policies that intentionally or unintentionally restrict the liberties of certain groups of people. One example that's been contentious debate in the public space past 3-4 years now is access to all gender restrooms for gender diverse folks. You can imagine that not being able to leave your home and safely access a restroom without fear that someone's going to call security because they're gender policing and tell you that you can't use the restroom, that would be really debilitating. I know several people who've been pulled out of restroom stalls by security guards because someone was policing their gender and which restroom they use, people who've developed kidney problems because they chronically intentionally dehydrate themselves to not have to use public restrooms. So all of that, as you can imagine, is a really detrimental source of structural stigma. And the third component of stigma we talk about is intrapersonal stigma. This is the kind of internalized homophobia and transphobia we were just referring to. This can be hard to shake even after someone is affirmed in their sexual orientation or gender identity, and can lead to a lot of shame and social isolation that is hard to work through. Important to understand the structural context and social determinants of health in which we serve LGBTQ youth. These are data from the National US Trans Survey that was done in 2015, published in 2016. 10% of youth in this survey, or 10% of people in the survey who were adults, reported that as youth, a family member was violent towards them because they were transgender. 8% were kicked out of the house because they were transgender. Many reported being seriously mistreated in schools, including verbally harassed, physically attacked, and sexually assaulted because of their gender identity. And 17% experienced such severe mistreatment that they had to leave school. So this is the climate in which we're serving these youth at school-based health centers. If we look at mental health disparities among cisgender, so non-transgender, gay and bisexual males, although admittedly this study didn't collect gender identity data, so there could have been some transmasculine folks in this study. Gay and bisexual males were more likely to meet criteria for major depressive disorder and panic disorder than the general population, and more likely to have at least 2 co-occurring psychiatric disorders than straight identified males. If we look at disparities among lesbian and bisexual females, more likely to meet criteria for generalized anxiety disorder and to have at least 2 co-occurring psychiatric disorders than their straight identified counterparts. If we look at prevalence of depression and anxiety among transgender folks, clinically significant depressive symptoms are at 51% among transfeminine respondents, 48% among transmasculine people. And if we look at clinically significant anxiety symptoms, it's 40% among transfeminine folks, 48% among transmasculine folks. This is, multiple times higher as a prevalence than what we see in the general population. Focusing on suicidality specifically among LGBTQ youth, compared with peers, LGBTQ youth are more likely to report suicidal ideation, are 4 times as likely to attempt suicide. There's a 30 to 40% prevalence of suicide attempts, not just ideation, among LGBTQ youth. And questioning youth are even more likely to experience depression or suicidality than their LGBTQ peers who have already settled on a particular identity. So this group is an especially vulnerable one that we need to be attentive to. Again, going back to that national survey of 28,000 transgender adults, it found that in the previous 12 months, 48% seriously thought about suicide, 24% made a plan to kill themselves, and 7% attempted suicide in the previous year. Of those that attempted suicide, which were 40% at any point in their lives. 34% had their first attempt by 13 years of age. 92% had their first attempt by age 25. So just take a moment to take those numbers in and appreciate the extent to which you can make a critical change in the lives of these youth that you're working with. It's really life-saving care that you're providing. How do we screen for, evaluate for suicide? And this is something many of you probably have a lot of experience with. I'd be interested in hearing your thoughts at the end once we get through the presentation. Thoughts that life is too, these are questions to ask youth that we're working with. Are you having thoughts that life is too difficult, may not be worthwhile anymore? That's getting at a death wish or thoughts of death rather than suicidal ideation per se. So this isn't yet getting to questions about whether they're thinking of taking their own life. Then thoughts of wanting to be dead. So this is really the death wish aspect of it. So we went from thoughts of death to death wish, thoughts of ending your own life. So this is getting at suicidal ideation. When, why did you start feeling this way, to understand precipitants and factors that are driving this ideation? Do you have a way you've thought about ending your life to get at a suicidal plan? Once they potentially answer yes to that question, you could ask if they would be willing to tell you how they're thinking of ending their life, how much they've prepared or rehearsed. Have they made a noose? Have they loaded a gun and put it to their head? Have they gone out and looked at train traffic patterns, for example? Do they have a date when they plan to attempt? Are there any contingencies? So what will it involve to potentially prevent them from attempting suicide? Will they make the attempt if they fail their next exam, or if their partner breaks up with them? So you want to kind of get at that information. Past attempts, this is a big risk factor for attempting suicide in the future. Have you attempted in the past? How close did you come? Were they hospitalized in the past? Did the noose break? Did someone find them and stop them? You want to try to get that information. Thinking of others, have they written a note? Have they said goodbye to anybody? Have they made preparations for people in their lives? Do they plan to do any of this in the future? All of that is helpful in terms of understanding their intent. How strong is their intent to actually attempt suicide? And what are protective factors? So a way to phrase this is, what keeps you going, as opposed to why haven't you done it already? Because that kind of sounds like it's encouraging them to do it. So what keeps you going? And people will often say their family, their partners, their pet, hope that it's going to get better at some point. So these are things you want to try to elicit as well. Are they engaged in behavioral health care? Do you have a psychiatrist or a therapist? If not, you really want to refer this person to care, and we'll talk about some referral models in a little bit. Do they have a safety plan? If they felt unsafe and like they were imminently going to harm themselves, who would they call? Do they have a friend, a family member? Would they call your school-based health center? Would they call 911? Would they go to an emergency room? So you want to have a safety plan with them. If the suicide attempt is imminent, it sounds like they're going to potentially cause themselves gross bodily harm in the next, say, 48, 72 hours, then you want to consider that a psychiatric emergency, and you may have to, unfortunately, hospitalize this young person against their will if they're not willing to go in. They may be willing to go in many cases people are. So then it's a conversation about how they get there safely. Focusing now on substance use disorders, and this is a huge risk factor for attempting suicide as well. LGBTQ people have disproportionate prevalence of substance use disorders, which we really understand now as a downstream effect of minority stress. Substance use has been found to mediate the relationship between life stress and sexual risk. So people cope with life stress by using substances. They're more likely to engage in higher risk sexual activities. Substance use disorders are associated with higher prevalence of condomless intercourse and are known to be barriers to adherence to HIV pre-exposure prophylaxis, PrEP, which you've been talking about on this echo, certainly. These are data from SAMHSA in 2015. They go down to 18 years old, so these data per se aren't for adolescents, although we'll talk about data for adolescents in a minute. But these show that in every age bracket, 18 and up, prevalence of misusing prescription pain relievers, basically opioids, is significantly more common among sexual minority people than sexual majority people. Lesbian, gay, bisexual, queer, and other sexual minority people are more likely to misuse opioids than their non-LGBTQ plus counterparts. Some other studies, sexual minority youth 16 to 25 are more likely to initiate misusing prescription opioids early in life than their sexual majority counterparts. Young men who have sex with men 18 to 29 have higher perceived stress associated with higher opioid use. So stress and the kind of minority stress we've been talking about is really thought to be a major driver of this higher prevalence of substance use disorders in the population. Among young Black men who have sex with men in Chicago, a study found that higher life stress was associated with higher odds of prescription opioid use again. And non-medical opioid use among men who have sex with men is associated with condomless intercourse and sharing syringes among MSM with IV drug use, which of course increases risk of HIV infection as well. Important note about substance use disorders among transgender people, these are really understudied, unfortunately, despite how high the risk is. And reporting of gender identity data in addictions research historically has been very limited. So it's hard to go back, do secondary data analysis and say, well, let's look at this older study and see what was going on with the gender diverse youth versus the other youth in the study. So it's hard to do that. That said, we've done some work with the NIH. Now, at least at the Clinical Center in Bethesda, they're required to collect gender identity data on all intramural NIH research moving forward, and we did the trainings for that with them. So we'll hopefully have more data prospectively. In the studies that exist, and they're starting to come out more and more, trans folks have higher prevalence of alcohol and illicit drug use compared with the general population. It's been found that psychological abuse among trans women as a result of their gender identity or expression is associated with higher prevalence of alcohol, marijuana, cocaine use, and of any drug use. Among trans feminine youth specifically, discrimination related to gender identity is associated with higher odds of alcohol and drug use. This was a study of 6,000 transgender people nationally. 35% who experienced school-related verbal harassment, physical or sexual assault or expulsion reported using substances to cope with mistreatment related to their gender identity. So this is often how people are coping in the absence of having a sense of community, being very isolated, difficulty talking to parents. So it's hard to soothe by engaging with others, and people are therefore often more likely to resort to using substances. In the same study, psychological stress of difficulty accessing gender-affirming care among gender diverse people is believed to contribute to worse mental health, including a higher likelihood of using substances to cope with lack of access to gender-affirming health services. This is a study we did in Massachusetts, 452 transgender adults. We looked at odds of substance use disorder treatment history plus recent substance use. It was really associated with a range of social determinants, intimate partner violence, PTSD, public accommodations discrimination, meaning discrimination in public housing, in discrimination in public transportation, public parks, public restrooms, hospitals, restaurants. We have a law prohibiting discrimination in public accommodations in Massachusetts that was on the ballot in 2018 along with the midterm elections to repeal those protections, and luckily the state voted to maintain those protections. Low income, unstable housing, and survival sex, which is unfortunately much more common in the context of having to leave school because of discrimination, being estranged from family, employment discrimination, and housing discrimination. It's important to think about substance use and post-traumatic stress together. Co-occurrence of substance use disorders and post-traumatic stress symptoms is highly prevalent across the population. It's associated with increased cost of treatment, decreased adherence to treatment, and worse both physical and mental health outcomes. It's important to understand as well that substance use and substance use disorders are a common avoidance strategy for post-traumatic stress. We think about, in many ways, post-traumatic stress disorder as a disorder of avoidance. In the moment, it's adaptive to dissociate so you don't experience the physical and emotional pain of an inescapable stressor you're dealing with. That said, if you don't at some point cognitively and emotionally process the traumatic experience, that's how we think PTSD develops. People don't recover from the acute stress the way that someone else might. And using substances is a way to numb and avoid that processing. Luckily, there's been a shift in community settings towards trauma-informed care, incorporating that into addictions treatment, and an appreciation of the fact that there really are evidence-based integrated therapies that target addictions, but also trauma and stress. And these integrated, what we call dual diagnosis treatments for post-traumatic stress and substance use disorders, are well tolerated and are found to improve both the addiction and the PTSD. It's hard to get traction on one with the other, so you have to really address substance use disorders to improve PTSD, and you have to improve PTSD to address the substance use disorder that's co-occurring. These are some, and we'll talk about them in more detail in a minute, these are some general minority stress treatment principles for clinicians. It's important to normalize the adverse impact of minority stress, particularly for younger people who may attribute challenges in their lives to personal failings rather than the stigma that exists in society. So if we can name that and help them discern when it's really minority stress at play, that can be very empowering. Facilitating emotional awareness, regulation, and self-acceptance. A lot of what your behavioral health professionals in your school-based health centers are already going to be very skilled at doing. Empowering assertive communication. For better or for worse, LGBTQ youth have to advocate for themselves in healthcare, in school, and in life. We do a lot of assertiveness training for people to know how to advocate for themselves, not engage in passive communication, not engage in aggressive communication, but hit it down the middle, engage in assertive communication. Restructuring minority stress cognitions, beliefs like no one can be trusted, no one will love me, it's never going to get better, which we hear a lot from youth. A few years ago, as many of you know, there was literally a public health campaign called It Gets Better to prevent LGBTQ youth from attempting suicide in the context of rising prevalence of attempts among these youth. Validating unique strengths of LGBTQ people. It's not all bad, right? This is a population with enormous resilience that's overcome tremendous obstacles and achieved greater integration into the mainstream fabric of U.S. society in just a few short decades. Obviously, there's a long way to go, but we can help young people feel connected to that strength and resilience of the community that can be very empowering and liberating. Fostering supportive relationships and community, that may initially be online for many youth who don't have visible LGBTQ communities locally. There are a lot of forums online and ways in which this occurs. And affirming healthy, rewarding expressions of sexuality and gender. I have patients who will be in the waiting room wearing clothes that are traditionally designed for the sex they were assigned when they were born. We'll call them in, they'll come back, they'll change in the restroom. We'll do this session with them, experimenting with new gender expression, maybe someone wearing a dress for the first time ever. We'll process what that's like. They'll then change, put their street clothes back on, and go out the waiting room in the health center that way. And that's a real privilege to be in a position to create that safe space for exploration with our clients, and encourage you all to think about how you can do that as well. There are terrific evidence-based treatments for many of these mental health problems that are more prevalent among LGBTQ youth, and that put them at risk for HIV, as we'll discuss in a moment, that can be tailored with that minority stress framework that we just went through. For example, there's a cognitive behavioral therapy manual for substance use disorders developed by Carol, available for free online on the NIAAA website. Focuses on coping with cravings, so triggers, managing cues to use substances, craving control, shoring up motivation and commitment to reduce at-risk substance use, clarifying and prioritizing the patient's goals, addressing their ambivalence about using substances, working on refusal skills and assertiveness, like substance refusal skills, passive versus aggressive versus assertive responding when you're in a situation where you may use substances, developing a personally tailored all-purpose coping plan that anticipates high-risk situations for using substances. And finally, there's an actual module in this standard CBT protocol for substance use disorders on HIV risk reduction. So based on what we've talked about in the minority stress framework, I wonder if folks want to weigh in for a minute on how they might tailor this intervention, the CBT protocol, for LGBTQ youth specifically. Feel free to unmute yourselves and chime in.
Alex, can you go back a slide so we can?
Sure. Yeah, definitely. There we go. And there are no right answers here. It's just brainstorming.
Hi, this is Maureen. I just wonder, especially as I go into a new school year and I get ready to make my presentation to my teachers, right? We had a few students who were transgender last year, and there was, I'm not going to say it was their policy that they wouldn't provide them a separate bathroom, but the undercurrent was such that they were not comfortable. And so they ended up coming into our little clinic to use the bathroom, which meant sometimes they were delaying their hydration, as you had pointed out earlier. So we had some real issues with, you know, just getting in enough normal water intake for this individual as well. I mean, what do you suggest that we say to the average teacher? I mean, who's not medical, what would be, and that in itself would be a part of the coping plan as you look at that, you know? Just curious.
Yeah, definitely. It's a great question, and you know, it's really well-intentioned what you did to have them use your restroom. We see that in homeless shelters too sometimes, where people will have the gender diverse folks use the staff restroom and no one else uses it. One downside of that is that it can inadvertently end up outing the gender diverse youth to other schoolmates, you know, as opposed to keeping that private. So, I mean, the direction things are going to have to move in eventually, and are moving in many places, including some schools, is to have all gender restrooms. Restrooms that are not binary in terms of being for men and women only. And there's different signage for that is available. You can see a lot of samples online if you Google all gender restroom images. I realize that that's a big culture shift. Many of us have been in situations anyway that aren't labeled all gender, where the restroom is, you know, there's stalls and people then share the sinks. I realize that that's besides being a culture shift, an expense for many schools to do so. It is really important to let people use the restroom that best fits their gender identity. Of course, if they don't feel safe doing it, then there's a cultural shift that needs to happen in the school, and that would require clear policies that are enforced by principal and all the teachers, that students are educated about this well and know that they're going to be held accountable if they police the restrooms that their classmates use. That would be my recommendation in a nutshell. In the meantime, if someone feels unsafe using either restroom and needs to be able to, I mean, just as an emergency measure, having them use single occupancy staff restroom sounds reasonable, but I don't think that's a sustainable approach. The school would really need to shift towards all gender restrooms over time and start the planning for that. Thank you for that question. And we'll have time to talk about that more later. So that's definitely one way in which to develop a coping plan. Focusing on minority stress-specific triggers for cravings, like ways in which discrimination and victimization occur related to the person's nonconformity in some way, and how that leads them to want to cope by using, how they are triggered to use when they experience expectations of rejection, when they feel like they have to conceal their identity, when they have thoughts related to internalized homophobia or transphobia, internalizing all the stigma holds about their identity. Thinking about substance use disorders as barriers to personalized goals for PrEP adherence, for example, or condom use, the ways in which this interferes with it. addictions can interfere with preventing HIV. And assertive substance refusal skills with non-transgender partners. It's often very affirming for gender diverse youth to be accepted in an intimate context in their affirmed gender identity, and that can reduce their power to negotiate not using substances during sex. And if they're engaged in survival sex and there's money involved, they have even less power to negotiate that. So really doing a lot of work around assertiveness can be critical. There's also a whole other category of substance use disorder uniquely seen among gender diverse people, which is medically unmonitored hormone use, masculinizing and feminizing hormone therapy that people can obtain off the street in the context of there being very limited access to gender-affirming medical care, particularly for communities of color. So we see what are called pumping parties, where people will inject hormones, inject silicone for body contouring, particularly among trans feminine people, and that certainly increases risk of HIV transmission by sharing syringes or hepatitis. So incorporating that into this evidence-based protocol. And then thinking about addictions as barriers to personalized goals for gender affirmation. I've had more luck getting people to stop at-risk substance use because they wanted to have gender-affirming surgery, and they knew the surgeon wouldn't move forward unless they have reduced their at-risk use than I've had, luck for any other reason. So there's such a strong drive for gender affirmation that can really be something that's harnessed to, in a sincere way, to reduce risk of, to reduce at-risk substance use. So these are just some ways in which you can tailor it. Cognitive processing therapy is an evidence-based treatment for PTSD specifically, and this focuses on education about post-traumatic stress, an impact statement that can be written or oral to help understand how trauma influenced the person's beliefs about themselves, about other people, and the world around them, and focuses on themes that come from Maslow's hierarchy of needs, so safety, trust, intimacy, control, power are among them. Identifying stuck points, so those very rigid all or nothing beliefs, like the ones we were talking about earlier, no one can be trusted, it's my fault, I deserved it, and how those are linked to emotional distress. So if we restructure those beliefs, emotional distress and PTSD can improve, and decreasing avoidance and increasing resilient coping. So how might you adapt this specifically for LGBTQ youth? And this is just the cognitive triad of traumatic stress from SAMHSA. Traumatic experiences will alter your views about yourself. So you may believe I'm incompetent, I should have reacted differently, it's too much for me to handle, I feel damaged. Views about the world, like the world's a dangerous place, people can't be trusted, life is unpredictable. And views about the future, like things will never be the same, what's the point, I'll never get over this, it's hopeless. So how might you adapt this specifically for LGBTQ youth?
I was going to share how to adapt one from the previous slides.
Sure. Yeah.
I had a recent transgender male patient who was in his early 20s, and he lives in northern Kentucky, and he had started, hormones within the year and was kind of in the process of socially transitioning, and he reported to me that he found a community of young queer and trans people that he really liked, and that was kind of a big moment for him. And he told me that a lot of them will use Coke socially when they're together, and that he just started using a lot of Coke. I saw him 3 months prior, and he had smoked weed a few times, and now he was snorting Coke all the time. And I was just like, oh my God. So, I had a conversation with him, and he was able to kind of identify that he was so happy to find a group of people that were affirming his gender that he felt comfortable with, that he just felt like he needed to do what they were doing to kind of fit into that group. And I was like, well, what would happen if you just didn't do the Coke, because it didn't seem like he really wanted to. He was just doing it for other reasons. And we talked about that, and he was kind of able to be really introspective. And then when I saw him 3 months later, I was really worried that he was going to report escalating use. And he was like, oh, I just stopped using Coke. And he said that he just didn't use it when the other people were using it, and it was a non-issue. And it was really kind of humbling to me, because I was prepared for a year-long intervention, and really all he needed was somebody who was, affirming his gender to give him permission to just try what it would feel like to not do it. So I think that you can't really underestimate how important that can be in a young person's life who is, LGBT, to just give them permission to do something differently can make a world of difference.
Yeah, that's a beautiful story. Thank you, Molly, for sharing that. And that it totally illustrates how desperate queer and trans youth are to belong, right, to fit in. And unfortunately, so much of our community among youth and adults has centered historically around using substances, of people getting together in bars or whatever the case may be. So, I mean, hopefully the teenagers aren't getting together in bars, but it's probably they're using substances otherwise. So, really kind of challenging that gently and giving permission to participate and engage without using. And it's often in someone's mind that they need to do absolutely everything the same way to fit in, and really other kids aren't necessarily paying attention to whether they're using or not. In some cases they may be, and in those cases I think those assertiveness skills are going to serve these youth well to be able to say no if they're being offered it, and in many cases hopefully it's not necessary as you described. So thank you for that. So some ways in which we can tailor CPT for queer and trans youth, focusing on how gender identity or sexual orientation specific stigma causes post-traumatic stress, how that leads to avoidance, mistrust of other people, hypervigilance that you're going to be found out, low self-esteem. Correctly attributing the challenges in your life to minority stress rather than personal failings. The cognitive distortions that often occur are, I'm worthless, no one will like me, it's my fault, I don't deserve it. So you really want to restructure those in a gentle way with Socratic questioning. So asking, is that always the case? When might things be a little different than that, to get people to become less rigid in their thinking, particularly adolescents who are going to be very concrete in many cases. The impact statement, written or oral, can be on how discrimination and victimization affected their beliefs about themselves, other people, and the world around them, how these have led to expecting rejection, to concealment needs, to internalizing all the stigma society has about their sex orientation or gender identity, decreasing avoidance, and that can mean decreasing isolation from other queer and trans youth or from medical care, reluctance because of often well-earned medical mistrust on our part as a medical community that queer and trans youth will have towards us. And really bringing in the PrEP adherence or condom utilization piece, this HIV prevention piece, can be part of the goals that you focus on in CPT. Important to note, young trans women and men who have sex with men are the two subpopulations in the US with the highest incidence and prevalence of HIV. ARBs for treatment and prevention of HIV require adequate adherence to be effective, as I'm sure you've been discussing on the ECHO. And studies of adherence to antiretroviral medications really emphasize population-specific contextual barriers. Our interventions need to be culturally tailored for LGBTQ youth. Discrimination and victimization of sexual and gender minority youth have both been shown to adversely impact self-care related to HIV. This is a study we did in the Bay Area with various community clinics and centers, showed that higher PTSD severity, as indicated by dissociation, so psychological detachment from reality, was associated with worse antiretroviral medication adherence. But the more severe PTSD is, the more likely people are to not adhere to antiretroviral medication. This is particularly important in a population where we're talking about minority stress that really plays out like PTSD does. So it's important to integrate psychosocial interventions that target post-traumatic stress to maximize adherence to antiretroviral medication, both as PrEP or for treatment. And integrating trauma-informed approaches into medication management, including PrEP, can really optimize adherence. So something to think about. And reforming your entire school-based health center and the school with a trauma-informed lens, thinking about ways in which, from the time people walk through the door to when they're in class to when they come to the school-based health center, they're not being triggered in terms of re-traumatization. And a big part of that is affirming their identities as LGBTQ youth. Biobehavioral interventions are highly effective. Tailored behavioral interventions exist for PrEP, like White Steps, and combining something like PrEP, an antiretroviral medication, with behavioral intervention to optimize care is found to be most effective. These are some interventions for screening and linkage to care. that we're implementing nationally now as part of a large $21 million project we're doing for the HIV/AIDS Bureau at HRSA, so the sibling bureau to BIFIC that funds all our school-based health centers. And we have 26 sites around the country where we're implementing these interventions. One that many of you may have, and I'm not familiar with data about the extent to which SBIRT is integrated into school-based health centers nationally, but I'd love to hear from folks on the session once we're done in a couple minutes. Screening, brief intervention, and referral to treatment. So the idea here is to initially screen everyone who walks through the door for a potential substance use disorder. And there are a number of screening tools that can be used for this. I'm happy to share these with you online. There isn't one particular one you have to use, but basically asking if they've used substances in alcohol in the past year, if they've used drugs in the past year. If the answer is no, then you reinforce the positive behavior. If it's yes, you ask further questions to assess the level of use and determine the extent to which it's at-risk substance use. And then you move into the second screening phase, which is further assessing those with a positive screen. If there's moderate risk use, then you do a brief intervention, which can be a brief negotiated interview to reduce their substance use. So the school-based health center provider would be trained to do a 5-minute intervention with them. And if it's high-risk use, then you would really refer them to specialized addictions treatment, which is going to be necessary in many cases. This is a really powerful evidence-based form of behavioral health integration into primary care that school-based health centers are very well poised to adopt. A second is collaborative care management for behavioral health. This was formerly referred to as IMPACT, which is the name of the study at the University of Washington in Seattle that generated a lot of the original evidence for this. It's a team-based approach where there's a consulting psychiatrist who would provide services at a distance. It'd be involved in initially helping with treatment planning, but it's primary care provider within the school-based health center, and what is in different situations referred to differently as a depression care manager or behavioral health care manager. It can be someone with a social work background, the nursing background, really a range of possible backgrounds can play that role. And after the initial assessment, the consulting psychiatrist would meet with the client, do a diagnostic intake, develop a formulation, develop a psychiatric treatment plan along with the primary care provider and this care manager who's working within the center. And then it's really the primary care provider and the care manager who manage the care, and using tools like the PHQ-9 to assess depression severity. And the idea is in basically 10 weeks, if PHQ-9 scores haven't dropped by 50%, the psychiatrist would get back involved, reassess the treatment plan collaboratively with the primary care team, and maybe make medication adjustments, for example, to ensure that we get these psychiatric disorders into remission. It's not just for depression. It's been studied now for PTSD, bipolar disorder, anxiety disorders, and substance use disorders as well. It really pulls together patient-centered care, population-based care, a measurement-based approach, evidence-driven, and fits into broader accountable care shifts in the healthcare system. This is a really cool intervention we're doing at several sites nationally. It's motivational interviewing with peers. So it's training peers to deliver motivational interviewing. We're doing this specifically in the HIV space with Black men who have sex with men. We're doing this in Jackson, Mississippi, and a couple of other places nationally among the 26 sites. The idea here is that you train peers, roughly age-matched as well. I mean, these would be young adults, presumably for school-based health centers, to deliver motivational interviewing to optimize adherence to HIV medications for prevention or for treatment. And these meetings can occur at the school-based health center or at other places in the community, depending on what would be the best fit and would best engage young people in care. Finally, I'm going to end on a note of emphasizing the importance of resilience for LGBTQ youth. This is really a cornerstone of trauma-informed care. Here's a definition from SAMHSA. This term refers to the ability to bounce back or rise above adversity as an individual, family, community, or provider. Well beyond individual characteristics of hardiness, resilience includes the process of using available resources to negotiate hardship and/or the consequences of adverse events. Here are some great strengths-based questions you can use with youth to promote resilience. These are again on the SAMHSA website. You can phrase this a little differently depending on the client you're working with, but the idea is to say something along the lines of the history you provided suggests you've accomplished a great deal since the trauma. What are some of the accomplishments that give you the most pride? What would you say are your strengths? How do you manage your stress today? What behaviors have helped you survive your traumatic experiences while they were happening and after? What are some of the creative ways you deal with painful feelings? What characteristics have helped you manage these experiences and the challenges they've created in your life? If we were to ask someone in your life who knew your past and your experience to name 2 positive characteristics that help you survive, what would they be? How do you gain support today? Could be family, friends, activities, coaches, counselors, other supports. What does recovery look like for you? So with that, we have a few minutes. Happy to hear any questions people have and have any discussion that would be helpful. Here's our website for more resources, lgbthealtheducation.org. We have many, many webinars, publications, and other resources focused specifically on LGBTQ youth, HIV prevention. We have a pre-exposure prophylaxis action kit we developed for the Bureau of Primary Healthcare that's available for free on our website, so feel free to peruse and check it out.
Thanks, Alex. That was great. Does anyone have any questions before we move to cases?
Can I say one thing? This is Renata. I just wanted to add, I think a couple points that you made, particularly I think that could be applicable in schools, because schools are sort of a very finite space. And sometimes I think that when you're in school environments, you feel like you have limited resources and limited access. And I think one of the things that has been shown to be effective for improving sort of the health outcomes, as well as addressing some of the minority stress and the gender minority stress that you talked about, Alex. Thanks for such a great talk. It are, GSAs and gay straight alliances. So there's really some great, it sort of speaks to your point about assertiveness training that, we did some groups here, and we found that youth that feel like they're more engaged in being able to advocate for themselves as well as be around other like-minded peers and gain some good coping skills and coping strategies. They're more able to, their mental health is improved, even without some of the family acceptance that we know is so critical. But finding that acceptance in other spaces is really equally important. And so I think if one thing for schools to, you all that are in schools to know is that you could try to work on having safe spaces and having the ability to develop these GSAs would actually speak volumes to the youth, as well as be able to provide some key resources in this area.
Thanks so much for sharing that. Yeah, GSAs are phenomenal, and I wish every school had one. That's really an important way. Part of what we talked about in terms of minority stress principles for clinicians is increasing engagement in community, and GSAs are a wonderful way to do that. Also to bring the non-queer and trans students on board in the process as allies has a lot of downstream benefits. So I appreciate you saying that, and if people have questions about how to get one started or support students to get one started at your school, feel free to reach out. PFLAG is also wonderful, which is Association for Parents of LGBTQ Youth, and they have chapters all around the country, so you can check out their website and find the closest chapter. That's really more for parents who are having a hard time, but we end up having to do a lot of family systems work. I know when Molly was with us at Fenway, that was something we would talk about a lot at the forum, our youth focus center. It's hard to do this work without bringing community on board. That means fellow students, family and guardians to the extent that they're in the picture. So thank you for that.
Thanks, Alex. I wanted to draw attention to a question that came through on the chat. So you mentioned online groups. So could you give some examples that could be provided to students?
Great question. Because I am a bit of a poser here in terms of the volume of adolescents that I work with, I am going to put my friend Molly on the spot, who is really the guru, and ask her to share the latest in terms of online community for queer and trans youth.
Sure, thanks, Alex.
Sorry.
No, it's okay. I was thinking while you were talking about how, you know, I'm in Cincinnati, which is right across the river from Kentucky, and I've heard through some friends that, or from some patients and some friends, that the Catholic Diocese of Kentucky will not allow Catholic schools to have GSAs. So I see a lot of patients who are from, you know, go to school, you know, high school and elementary school in Catholic schools, and then there's also a Catholic college right across the river, and they're not allowed to have a GSA either. So, you know, I definitely have to get creative with my patients about trying to figure out ways that they can have community. Something that we actually do for our parents, but you can also do for young people, is private Facebook groups. I know young people now think that Facebook is like what the dinosaurs used. So you can apply that to other social media, but I know the one that we have for our parents, one of the social workers kind of moderates, and it would be probably good to have an adult kind of involved in a secret and private Facebook group for adolescents, just to make sure, you know, we're keeping it PG, but it is a good place where kids can at least, you know, express themselves and feel accepted in, you know, some kind of environment. You know, a lot of my, and I always talked about this with my patients when I was at the Borum in Boston, but a lot of my young queer and trans patients find community through like gaming, like online gaming, where you're like playing as an avatar with other people. And they're definitely like queer and trans friendly gaming communities. And I know a lot of young people are doing that. And the cool thing about that is that you can like be different avatars. So a lot of times, you know, I've had patients who have kind of come to the realization about their gender identity through being different avatars on games. So those are the two things that I, off the top of my head, and definitely PFLAG is more for parents of queer and trans people, but they also are like, tend to be really well-resourced groups that can help you figure out ways to start other groups. I know when I was in Boston, there was a specific PFLAG group for parents of young trans kids, which was helpful because then the kids of those parents would often hang out, and that can be a helpful way too, is helping. I mean, I know it's hard when you're in school and like maybe the parents aren't supportive, so you need to find a way for the kids to be able to interact without parents involved. But for parents who are supportive, figuring out a space, you know, where parents can interact and the kids can interact can be helpful also. I know that our Facebook group, a lot of times parents will make connections on the Facebook group and then their kids will hang out. So there's a little bit of community building there. Also, I mean, in the South, in the, you know, up South, which is what I identify Cincinnati, and in the South, there are definitely like churches that are more accepting and youth groups that are more accepting, and that can be a place where queer and trans kids can, you know, you obviously have to like know about the church groups that are around you. But yeah, it can be really hard to get creative, and I'll ask our social worker for other websites that she knows of that our young people use, and I'm happy to send out a list. But a lot of times it just involves getting creative, which is hard, especially with minors, because you don't want to steer them into something that is like illicit or illegal, but you also want them to be able to like commune online, even if that's their only option.
I would also say the Trevor Project is really wonderful. So the Trevor Project can be, we share that with providers and youth here and use it a lot. And so they have a 24-hour access that's accessible. And I think that it's a really good tool for youth to find support. Also, HRC has some good resources for both youth as well as parents and allies that, basically HRC has a list of resources that can be used, gender spectrum, youth family allies, to name a few. So I think that those are some resources that are very helpful, but I would definitely recommend the Trevor Project and HRC.
Yeah, that also reminded me of the Family Acceptance Project out of San Francisco. They have some really good resources. I think I mentioned them in my talk I did a few months ago. And then the other thing about the Trevor Project, and maybe we've talked about this too, but I can't remember, they have a really great suicide hotline for queer and trans young people. And a lot of times when I'm doing safety contracting with my patients, that often is like what my patients identify as something that they would feel comfortable doing if they don't feel safe, and they could see themselves utilizing it if they needed to. So that's a really great resource too.
Yeah.
Thanks, everyone. Thank you for your time. It's been a pleasure. And I'm happy to stay and answer more questions. I know you have some cases too.
Thanks, Alex. All right, so we are gonna transition to cases.